If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we're reviewing the NICE guideline on hypertension in adults, always focusing on what is relevant in primary care only. In previous episodes, we covered the diagnosis, criteria for urgent referral, when to start drug treatment, and blood pressure targets. Today, we will focus on antihypertensive drug treatment. Right, let's jump into it. Let's start with what antihypertensive treatment to choose. The recommendations in this guideline apply to people with hypertension with or without type 2 diabetes. But for people with type 1 diabetes or CKD, we should refer to the relevant NICE guideline. We should also remember that ACE inhibitors and angiotensin receptor blockers should not be used in pregnancy, breastfeeding, or when planning pregnancy, unless absolutely necessary. If used, we must discuss risks and benefits and follow safety guidance. In general, and if possible, we should choose once daily treatment. For isolated systolic hypertension, defined as a systolic blood pressure of 160 or higher, we should treat in the same way as people with both raised systolic and diastolic blood pressure. We should offer antihypertensive drug treatment to women of childbearing potential with diagnosed hypertension in line with the general guideline on hypertension. For women planning pregnancy who are pregnant or breastfeeding, we should manage hypertension in line with the specific NICE guideline on hypertension in pregnancy, including guidance during breastfeeding. When choosing antihypertensive treatment for adults of Black, African or African Caribbean family origin, we should consider an angiotensin receptor blocker or ARB in preference to an ACE inhibitor. This is because ACE inhibitors may be less effective in this group, partly because low-renin hypertension is more common, and they also carry a higher risk of angioedema. For people with cardiovascular disease, we should first follow the disease-specific recommendations in the relevant NICE guideline for their condition. These include acute coronary syndromes, acute and chronic heart failure, stable angina, and type 1 diabetes. If blood pressure remains uncontrolled despite following these disease recommendations, we should then offer the general stepwise approach outlined in the hypertension guideline. Let's have a look at it. As step 1 treatment, we should offer an ACE inhibitor or ARB if they have type 2 diabetes, regardless of age or family origin. We should also offer an ACE inhibitor or an ARB to adults under the age of 55, provided they are not of Black African or African Caribbean family origin. If an ACE inhibitor is not tolerated, for example because of a cough, we should offer an ARB instead. We should not combine an ACE inhibitor with an ARB. We should offer a calcium channel blocker as type 1 treatment if they're aged 55 or over and do not have type 2 diabetes. We should also offer a calcium channel blocker to adults of Black African or African Caribbean family origin who do not have type 2 diabetes, regardless of age. If the calcium channel blocker is not tolerated, for example because of edema, we should offer a thiazide-like diuretic. Equally, if there's evidence of heart failure, we should offer a thiazide-like diuretic and follow the NICE guideline on chronic heart failure. If starting or changing diuretic treatment, we should prefer a thiazide-like diuretic, such as indapamide, over conventional thiazide, such as benzoflumethiazide or hydrochlorothiazide. If blood pressure is stable and well controlled on benzoflumethiazide or hydrochlorothiazide, we should continue the current treatment. Now let's move on to step 2 treatment. Before considering the next step, we should discuss with the person whether they're taking the medications as prescribed. If blood pressure is not controlled on step 1 treatment with an ACE inhibitor or an ARB, we should offer one of the following in addition: a calcium channel blocker or a thiazide-like diuretic. If blood pressure is not controlled in adults taking step 1 treatment with a calcium channel blocker, we should offer one of the following additions: an ACE inhibitor, an ARB, or a thiazide-like diuretic. For adults of Black African or African Caribbean family origin without type 2 diabetes, no control on step 1 treatment, we should consider an ARB, in preference to an ACE inhibitor, as the add-on treatment. Now let's move on to step 3 treatment. Before considering the next step, we should make sure that optimal tolerated doses are being taken, and we should discuss adherence. If blood pressure is not controlled on step 2 treatment, we should offer a combination of 3 drugs, that is, an ACE inhibitor or an ARB plus a calcium channel blocker plus a thiazide-like diuretic. And finally, let's move on to step 4 treatment. If blood pressure is not controlled despite optimal tolerated doses of an ACE inhibitor or an ARB, plus a calcium channel blocker plus a thiazide-like diuretic, we should regard this as resistant hypertension. Before considering further treatment, we should confirm the elevated clinic readings using ambulatory home blood pressure monitoring. We should assess for postural hypotension, and we should discuss adherence. If resistant hypertension is confirmed, we should consider a 4th antihypertensive drug or seek specialist advice. If considering a 4th drug, we should consider adding low-dose spironolactone if the blood potassium is 4.5 millimoles per liter or less, using caution if kidney function is reduced because of hyperkalemia. When starting further diuretic therapy, we should monitor sodium, potassium and renal function within 1 month and repeat as needed. If potassium is above 4.5, we should consider an alpha blocker or a beta blocker instead. If blood pressure remains uncontrolled despite 4 drugs at optimal tolerated doses, we should seek specialist advice. So that is it, a review of a section of the NICE guideline on hypertension. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.